I must say it is my great honor to have an opportunity to present about robotic thymectomy. I'm Changhyun Kang from Seoul National University Hospital. My major interest is robotic surgery, and I'm now performing robotic surgery for thymic tumors, esophageal cancer, and lung cancer. Today, I will present about robotic thymectomy. I hope this lecture will be helpful for beginners in robotic thymectomy and the other surgeons who are going to expand their own robotic programs. Today, I will present three topics on robotic thymectomy. The first one is a review of the literature on robotic thymectomy. The second one is the technical modifications of robotic thymectomy, and I'll show you some video clips. And the last one is the outcomes of robotic thymectomy in our hospital. Currently, we have three types of surgical methods in thymectomy. The first one is the cervical thymectomy, which has the longest history. Many centers in Western countries are still performing transcervical thymectomy. However, the indication is mainly limited to treating the non-thymomatous myasthenia gravis. The second one is a transsternal thymectomy. It can be subdivided into full sternotomy or partial sternotomy. It was used as a standard surgical modality before minimal invasive surgery was introduced. Minimal invasive thymectomy is the most popular surgical method for early stage thymic tumors. BAS or robotic surgery is available currently. However, there are many various modifications of minimal invasive surgery according to the location of a port and the number of ports. Today, I will talk about robotic thymectomy and its variations. What is the current trend of minimally invasive thymectomy? I think the preferred surgical methods depends on the situation of each country. This graph shows the current trend in the United States. This paper included the patients with non-thymomatous myasthenia gravis in STS database. Robotic thymectomy is rapidly increasing, and transcervical and transthoracic thymectomy is decreasing. The VET thymectomy is stationary for the last 10 years. Currently, robotic thymectomy is the dominant procedure in the United States. The advantages of robotic surgery are well known. 3D vision, free articulation, and 10 times magnification are the basic advantages over thoracoscopic surgery. Using these features, we can realize benefits during the operation. We can perform fine and meticulous dissection even in a very small space. We can also make ports freely without the limitation of human arm movement range. Therefore, many different kinds of modifications are possible according to the surgeon's preference. As a result, by using robot, we can perform very complex operations. Currently, many centers in the world are performing robotic thymectomy. These papers are the studies published between 2020 and 2021. Number of cases, complication rates, and the length of hospital stay were variable according to the studies. However, generally, most centers reported favorable early outcomes in robotic thymectomy. Recently, several meta-analyses comparing robot and open or BAS were published. This is a study on meta-analysis comparing robot and open surgery. 14 studies with more than 3,000 patients were included in this study. In this study, robot thymectomy showed less blood loss and less positive margin and shorter length of hospital stay and lower post-operative complication rate than open thymectomy. The hospital stay was reduced by 2.7 days and complication was reduced by 63%. This study is another study comparing robot and BAS thymectomy. Robotic thymectomy showed less blood loss and less drainage volume, shorter drainage days, shorter length of hospital stay, and lower complication rate than BAS thymectomy. The length of hospital stay was reduced by 1 day, and post-operative complication was reduced by 47%. Although the difference was smaller than the comparison with the open thymectomy, the difference was statistically significant. Studies on the effect for myasthenia gravis are quite rare. This is an old study comparing robot and bats to accomplish a complete remission of myasthenia gravis. In this paper, the robot group shows a higher CR rate than the bats group. The difference was 19%, and the difference was statistically significant. However, in this meta-analysis study, the same raw data from the previous study were reanalyzed by different authors. In these papers, authors reported that the 3-year remission rate was higher in the robotic group. However, 5-year remission rate was not different between groups. According to this study, it is difficult to say the robot is better than best at controlling myasthenia gravis. More studies on this issue are necessary. Another issue is the approach. Historically, the lateral approach was the first approach used in robotic thymectomy. However, recently, subxiphoid approach being used popularly. If we compare the lateral approach and the subxiphoid approach, the subxiphoid approach has several advantages: wide surgical view and easy to do the complex procedures, and furthermore, post-operative pain is reduced. However, put insertion and arm handling is difficult than the lateral approach. Therefore, some experience is necessary to do the subxiphoid approach without difficulty. We recently published a study comparing lateral and subxiphoid robotic thymectomy. 141 patients in each group were included after propensity score matching. In this study, the subxiphoid approach was performed more frequently in the tumors abutting the innominate vein, and innominate vein resection was more frequently performed in the subxiphoid approach. It means more complex operations were performed in the subxiphoid approach. However, post-operative pain score was lower in subxiphoid approach, crossing the whole post-operative period. I think the subxiphoid approach is a better approach than the lateral approach in robotic thymectomy. Long-term survival is the most important issue in the surgery of thymic epithelial tumor. Only a small number of studies have been published in robotic thymectomy. These 3 studies are recently published studies reporting the long-term survival. As you can see, most of the studies included early-stage tumors and reported favorable long-term survival. The first paper included 53 patients with thymoma and reported 4 recurrences and 2 deaths. And the second paper included 84 patients with heterogeneous disease, including thymoma, lymphoma, and others, and they reported only 1 recurrence. The last paper is our paper, reported long-term outcome on the thymoma and thymic carcinoma, and the long-term survival was favorable. This is a recently published paper comparing minimally invasive thymectomy and open thymectomy in stage 1, 2, 3 thymic carcinoma. They collected data from the National Cancer Database of the United States from 2010 to 2015. Overall, 216 patients were identified, and minimal invasive surgery was performed in 43 patients, and 22 patients underwent BAS, and 21 patients underwent robotic surgery. They performed propensity score matching and compared the early and long-term outcomes. 30-day mortality and R0 resection rate were worse than those of thymoma. However, there was no difference between groups. The 5-year survival rate was 75% in the minimal invasive surgery group and 54% in the open surgery group. Although the absolute difference was large, however, the p-value was 0.15 and the difference was not statistically significant. The authors concluded there was no difference in the short-term outcomes and the long-term survival even in thymic carcinoma.